Hello. We're off. Can you hear me okay? Ladies and gentlemen, it is indeed a huge pleasure to welcome you to this day in such an august venue at the time of a significant anniversary in its history. I'm Dr. Jerry McCarthy. I'm clinical lead for the National Emergency Medicine Programme. You're all very welcome. And I'm a consultant in emergency medicine at Cork University Hospital. The diverse background of the audience reflects the theme of the day, really, which is interdisciplinary and interprofessional working that's involved in the delivery of healthcare in the acute hospital setting, and indeed that's a reflection of the delivery of healthcare and the wider healthcare system in 2016. The tagline for the day is "Teamwork delivers better patient care." Our first session in a few moments. Curious? This guy is going to stand. No, he's not. Our first session is a vignette presented by some of our specialist registrars and nursing staff and facilitated by Dr. Doherty, who's a clinical psychologist and also Director of Human Factors Training in RCSI. The session illustrates how in the hurly-burly of the delivery of multiple parallel episodes of patient care to large numbers of patients, what my colleague Dr. Chris Luke often calls industrial-scale medicine, it is always the case that the single most important patient is the patient in front of you. It also emphasizes the importance and vulnerability of that moment of clinical handover in the chain of the delivery of emergency care. This is then followed by a number of presentations of projects that have been supported by the Emergency Medicine Programme, leading to the development of tools to assist us in the delivery of these multiple parallel episodes of care to patients whose needs often present varying degrees of clinical urgency. So that's a session around the tools that we feel we would recommend as useful for helping us patient care. The morning session then closes with a presentation by Dr. Abel Wakai, consultant in Beaumont, about the development of exemplars of clinical care into clinical guidelines. You get a break. And then the afternoon opens with my colleague, Dr. Jason van der Velde, who works with me in Cork and does a huge amount of pre-hospital care. This is another human factors session. Jason will present a video montage speaking to the importance of interagency working, so not just HSE and hospital staff, but interagency working in ensuring the safe and efficient retrieval of the patient who has developed a sudden significant illness or injury at the roadside or indeed on their kitchen floor, and their safe delivery to hospital. This is followed by a session led by Dr. Unagiri, my predecessor as clinical lead of the national programme, about clinical microsystems. This is the quality improvement and assurance programme recommended by the EMP. This session will include presentation by a number of people of some of the QI projects that have been delivered in emergency departments in the country. Then Dr. Cliff Mann, who hopefully is in the air, President of the Royal College of Emergency Medicine, in the air as we speak and will have landed by the time he speaks, will address the factors that need to be continuously worked upon. I see the CEO of Cork University Hospital, Tony McNamara, in the audience, who assures me that he never stops thinking about the emergency department. The factors that need to be continuously worked upon inside and outside the emergency department to optimise the delivery of patient care in the emergency setting. So that's Cliff Mann, the President of the Royal College of Emergency Medicine. The afternoon will then close with a session chaired by Dr. Aine Carroll, National Director for Clinical Strategy and Programmes, and she who approved the budget for the day. So, with presentations from the clinical leads of the 6 clinical programmes with whom we work most closely. This speaks to the convergence of the national clinical programmes and the delivery of best patient care. Finally, Dr. Cullum Henry, National Clinic Advisor and Group Lead for acute hospitals, will close that session probably with a dose of reality. Thank you for your attention. Our Twitter handle is #EMP2016. Just before I hand over to Dr. Eva Doherty and colleagues for a session about the fundamental importance of communication in clinical handover, I'd like to mention one of our intended speakers who was unable to attend today to talk about ambulance handover. Dr. Niamh Collins, consultant in emergency medicine in Connolly Hospital. Niamh's father, Professor Patrick Collins, took ill recently and died yesterday. May he rest in peace, and condolences to Niamh and her family. And now it's over to you, lads. Thank you.
Hi guys, I think you're expecting this patient patient.
Yeah, we've heard about him. We got the handover on the phone. Yeah,
just
no, that's
hand
grand.
over there.
Just get him registered. We heard about him on the phone.
Alright,
Not
so,
everywhere.
grand.
There's something here in his
You get
chest.
some IV access. That's only a scratch. Don't worry about that.
Okay, we'll cover him up there. Just
Yeah.
going to put a blood pressure
Get some.
pump on your arm.
Yeah. Okay. Get some obs. Get some IV access. I'll keep some pressure on this.
Pop
Oh
on
yeah.
check it.
You call the surgeons. There's blood everywhere. It's coming from his neck.
Look, yeah, okay.
Quick.
Hi, surgeons, please. Surgeons on call.
Yeah, so I have a cannula in his
Hello,
arm here.
surgeons. Hi, sorry,
Will I take some blood?
we need you now down
No.
here. Now, sorry, ED here. And where's he bleeding from? It's from bleeding fibula. What is I mean, where's the blood coming from? Oh, sorry, it's burning out his neck. We can't get control of it at all. And what's his
It's just bleeding
vitals?
through on
Oh
you.
yeah, sorry.
Oh,
Okay,
yeah.
we're just getting hooked up on a monitor now, but he looks very pale. He's not talking at all. I can see blood coming out his mouth.
Right. Do you have hemoglobin?
Yeah, do we?
Oh, sorry.
Yeah. It's 11.
11. Yeah, that doesn't sound too bad. Listen, can you get a scan and I'll talk to my reg? Okay?
Okay.
Lovely. Thanks. Bye. 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 Bye.
Anya, I can't control this bleeding. Are they coming?
She's going to talk to her reg, but she wants us to get a scan before they come
Who's
down.
that? The
I'll talk to
SHO?
the
That's
radiologist.
for fixing. You shouldn't rang the reg. Get another IV access. That's surgical reg?
Yeah, hello?
Yeah, I've got his man down here. He's standing
Yeah, I know. My SHO spoke to me about this patient already. I'm up to my eyes in clinic. Give me a ring when the scan is back. The SHO is on her way down. Thanks.
How are we doing, guys?
Yeah, I've got that IV line in. Yeah.
Is the blood on the way?
Did anyone send a cross match?
Did you get
What?
own egg?
No, nobody rang.
Great, guys. He's all registered.
Great,
Listen,
yeah.
Arthur, what do you think of his left side of his chest? I couldn't hear anything at all. And they
Guys,
think he was
we've a
stabbed
pulse.
with a
The chest?
screwdriver.
What?
Chest. Yeah, yeah.
Good morning, everybody. So, as Jerry said, my name's Eva Doherty. I run the Human Factors training in the college with the emergency medicine trainees and the surgeons, and delighted to be with you today. This is very much a demonstration of what we do. So we simulate scenarios like this to try and get across important factors. And so human factors is all about people, working with people, interacting with machines in very complex environments, and there's all sorts of potential there for error. And human factors works from the a priori assumption that human beings are fallible. Yeah, so we make mistakes. So we need safety nets in place to rescue us and to stop harm coming to patients, and human factors is all about that. I want to go very quickly to tell you about a guideline which you may or may not have heard about, which was launched by the National Clinical Effectiveness Committee here in this room at the end of November. It's the Communication and Handover Guideline. And I urge you to take a look at it. The summary document is very easy to find up online, and also the longer one, which has all the evidence in it to back it up. And I was lucky enough to be invited to be involved in this. So it's a matter that's really close to my heart. And before I hear you say, "Oh no, not another guideline," we're run away with protocols and signs and all kinds of things, this is definitely one that should be up on your wall in work. So can I introduce you here to the ISBAR 3? So many of you are probably familiar with ISBAR. This is ISBAR with a bit of a difference. It's ISBAR 3. And essentially what that means is that not only do you identify yourself and your patient and even introduce, why you are talking to the person, what you need from them, but also you describe the situation, the background, your assessment, your recommendation, and then your recipient needs to read back to you, needs to say back to you what they've heard, because this is where the misunderstandings can happen. And also what's important is to communicate risk. Is there anything going on in the hospital today that might make things more difficult? I'm anticipating, because we've done some training on this in the college already, and I'm anticipating that what you're thinking is this readback business isn't going to work. People are not going to repeat back what they've heard. It feels counterintuitive, it feels a bit weird. But what I want to remind you is that there's lots of other environments outside of hospitals that are doing this all the time. So they do it in McDonald's. So you go into McDonald's and you give them your order. What happens? They say it straight back to you, don't they? They say, so that's a quarter pounder, large fries, Diet Coke. And you say, no, I'd like a Fanta. Okay, so if they're doing it in McDonald's, it's good enough for us in the hospitals. Here's the safety pause. So this is a reminder, which also should be up on the wall along with the ISBAR 3 and beside the phones. And this is a reminder to include what are all the potential risks. So is there staffing problems in today? Are there infection risks? Is there bed problems? All those kinds of things. Okay, so now I invite the guys to come back and girls and show you how it should be done.
Okay, guys, we're after getting a call from ambulance control. We've got a 22-year-old coming in. He's got a couple of stab wounds. He's quite unstable, apparently. So, Aine, I'm going to ask you to do the primary survey. Keane, you might get some monitors on, and Helen, you might get some IV access, get some bloods and a group and cross match. Okay? He's not.
Got it.
Okay.
No, fine, guys. I think you're expecting this time.
Yeah, that's great.
No.
Hi, I'm Martha, one of the SBRs here.
I'm Joe. I'm one of the APs on scene. This is Sean Joe, 26-year-old male stab victim. We received a call of domestic stabbing about 30 minutes ago. We were 22 minutes ago at scene. He's 2 visible stab wounds, one on his anterior right side of his neck, it's bleeding quite profusely, and one on his left anterior chest wall. Not bleeding very much, but I'm concerned about cardiac or great vessel damage. So when we got there, he was seated up tunded, he was tachycardic, tachypnic, he was tachy at 150, blood pressure of 80 on 30 on arrival. We're using direct pressure there to control the bleeding on the neck wound, and we've caldostatin gauze there, we've packed underneath the tongue as well. I have a 3-sided dressing on the chest wound. We've an IO in situ in his left hip fib. He's a litre infusing with tranexamic given. His latest obs there are 92% on 15 litres, non-rebreather. Heart rate was 140, BP 85 on 40, respiratory rate 16 and GCS 7.
Okay, that's great, Joe. So we've got a 22-year-old man with stab wounds to the neck and chest. He's tachycardic, hypotensive, and tachypnic, and you're concerned about a significant left chest injury.
Absolutely. Just no allergies, no meds, no background history.
Okay.
Anything else at all?
No, that's great.
We'll
Okay,
get him
now we're
registered.
getting on here.
Thank you.
Yeah, just did a primary survey. So
Yeah.
he's maintaining his airway at the minute, and it's patent, but there's an awful lot of blood in his mouth, and he's going to be better with an RSI.
Okay.
Regard to breathing is factor 90 in the non-rebreather. I can't hear any air on this left side, and it's dull to percuss. Underline that stab wound, I'm afraid he's got a massive hemothorax. So we're going to have a chest drain at some point straight away. Circulation-wise, it's now reading 70 on 40.
Okay.
And his heart rate is up to 150.
got blood on the way?
We've gone for group and cross matching, no negative en route down. Yeah.
Great, okay. So he's low GCS, there's a lot of blood in the airway. It sounds like we're going to need an RSI. Maybe you might set up for that. Helen, will you set up for a chest drain? Aine, will you get a fast scan done while they're setting up for that? And I'm going to contact the surgeons, okay? Hello, is that the surgical reg?
Hello, yeah.
Hi, I'm calling about a man who's come into us. He's 22-year-old. He's been stabbed in the left neck and chest. He's tachycardic, tachypnic, and hypotensive. We're going to need your assistance here. We're going to set up for an RSI. We're concerned that he has a massive hemothorax, so we're getting a chest drain into that. I feel he's going to need to go to theatre ASAP because he's so unstable.
Okay, so just to summarise, Arthur, you have a 22-year-old male who's come in following a stabbing. He's a wound to his right neck and left anterior chest wall. He's hemodynamically unstable, and you think he needs to go to theatre immediately.
That's it, yeah.
Okay, so have you spoken to anaesthetics, Arthur?
No, I'm getting onto them after you, yeah.
So if you speak to anaesthetics, Arthur, I'll talk to my consultant. The only problem at the moment is I know ortho have a case in emergency theatre, so I'll get on to theatre and I'll get back to you as soon as possible. We'll be down. Thank you.
Okay, that's great. We'll see you shortly. Okay.
So that completes our vignette. Thank you very much.